At the Nocturnist, we are careful to ensure that all stories comply with healthcare privacy laws. Details may have been changed to ensure patient confidentiality. All views expressed are those of the person speaking and not their employer.
As physicians, we get to know patients in a different way than they know themselves. We become intimately familiar with their diseases, their lab values, and radiology images. But beyond the medical chart, who our patients actually are may be a mystery. I'm Emily Silverman, and this is The Nocturnist, stories from the world of medicine. In this episode, Hospitalist Peter Barish recounts an intimate experience he had with a patient he knew next to nothing about. In the conversation that follows, we discuss what it means to know our patients. Here is Peter Barish.
So, one of my favorite movies I saw this year was Ladybird. And it's a small movie in a lot of ways. It is shot as a series of intimate moments. And it's a love story between a mother and a daughter, between friends, between a girl and her hometown. When I was in my last year of residency, I admitted a young girl to the ICU whom I'll call Jessie. She was transferred from a small town hospital a few hours away, and she was transferred with a terrible infection. By the time she got to us, the infection had spread to her lungs, and so she was intubated. She was on a ventilator. It's one of the challenging aspects of taking care of patients in the ICU that a lot of times they can't speak to you. They can't tell you their stories, and you're left figuring out their stories on your own. The first thing I actually noticed about Jessie was that she and I were the same age, and she looked quite young, which, as you can see, is a curse I also share. And I felt this instant connection to her that you feel sometimes as a young physician taking care of an especially young, sick patient. And even though Jessie couldn't talk to me, I caught glimpses of her past life by paying attention to her disease. How a long-standing addiction to heroin had led to this terrible infection that was now ravaging her lungs. As often happens in the ICUs, things got crazy and we went on focused on other things, and I kind of put Jessie out of my mind for the rest of that day. And then at 1 a.m, I get a page from the nurse asking me to urgently come to the bedside. Jessie's ventilator was alarming. It was telling us that there was too much pressure in the system, which can happen for a number of different reasons, some of them benign, some of them not so great. And we get a chest x-ray, and it shows that Jessie's entire right lung has collapsed. She has a massive pneumothorax. A pneumothorax is something that happens when air gets into the lining of the lung and then can't escape. In Jessie's case, one of the pockets of infection had popped, and so the ventilator was forcing air in, but when it couldn't get out, it crushed her lung. I'm now vividly recalling a conversation I had with my attending 8 hours earlier when he handed me an almost comically large needle in sterile packaging, and he said verbatim, "Peter, you should carry this around with you in case Jessie gets a pneumo in the middle of the night." What he was really saying was, "Peter, you should keep this in your pocket because if at 1 a.m, Jessie's lung collapses and so much pressure builds up in her chest that blood can no longer flow back to her heart, you should come in here and take this and stab it into the middle of her chest to relieve the pressure." It's kind of like that scene in Pulp Fiction, but 4 inches to the right. And I said, "Excuse me?" And he said, "Don't worry, you'll be fine." So I'm watching Jessie's blood pressure cycle, thinking, am I actually going to have to John Travolta this 30-year-old? When thoracic surgery comes to the bedside, we had paged them urgently because they were there to put in what's called a chest tube, which is basically a long hose the diameter of a Sharpie. And it's surgically implanted between the ribs for situations just like this. The tube goes in and we hear a rush of air, which signifies that Jessie's lung is re-expanding. And it works, she goes back to being stable. And the extra long needle stays in its sterile packaging. But now I'm basically tied to her bedside for the rest of the night, nervously checking her ventilator every 15 minutes. And so I'm there in her room an hour and a half later when her entire left lung collapses. I'm thinking, I've never seen this before. This seems very bad. And the surgeons come back to the bedside, and just as they're about to do their thing, the chief surgical resident gets a page from the emergency room. There's been a gunshot victim that's just come in, and he says, "Oh, I have to go." And so he and most of his team leave, and they never come back. And so it's just me and this second-year surgical resident standing at this bedside counting rib spaces. And fortunately for all of us, this resident, despite his relative lack of experience, still had a that surgeon's attitude of, fuck it, let's go. And so he, by himself, put in what would be Jesse's chest tube number 2. And after this night, I developed this almost constant vigilance around Jessie, checking and rechecking her blood pressure and heart rate and interrogating small changes in her CO2 and oxygen levels as if they portended some impending catastrophe. And these things kept happening. Different parts of her lungs kept collapsing, and she needed more and more chest tubes to drain out the air and the fluid. And about a week after she's initially admitted, my fellow comes to me and asks me if I would like to put in what would be Jessie's last chest tube, her 6th. Now, this isn't a procedure that medicine residents typically ever do. It involves making an incision between the ribs, typically under the arm, and dissecting down with a scalpel until you hit to the lining of the lung and then puncturing through with a pair of scissors. So I'm at her bedside prepping for the procedure, and I look under her arm, and I notice that Jessie has a tattoo on her ribs under her right arm. It's a flower. It looks like a lotus. And so to avoid scarring the tattoo, we decide to go one rib space down. Now I'm leaning over her bed and using almost, it feels like my full body weight on these scissors, and I finally pop through and I hear a rush of air and fluid that tells us we're probably in the right space. But you have to do a little bit more dissection with your hand to make sure you are where you think you are before putting a Sharpie-sized hose into someone's chest. I'm feeling with my hand under her rib, and I can't quite tell if I am where I think I am. And then I feel something tap the edge of my hand. And I pause. And I feel it tap again, and I realize that it's Jessie's lung. With each breath of the ventilator, her lung is expanding and reaching out to tap my finger. The ventilator's going at 22 times a minute, and so 22 times a minute, her lung is tapping the edge of my hand. Tap, tap, tap. Now, to be honest with you, after a few years of residency, I'm not the kind of person who was often awed by things that I saw in the hospital on a day-to-day basis. But this completely took me out of myself. Standing with my hand between Jessie's ribs, I realized not only how intimate this moment was, but that also, as long as I was a physician, I would most certainly never do this ever again. A couple weeks after this, I rotate off service. I go to another hospital, and I never see Jessie again. She did eventually leave the ICU on the ventilator. Her lungs were never quite strong enough to breathe on their own, and so she went to another facility to try to get better. And then 4 months after her initial admission, she would come back to the ICU, but this time she would walk in. She came back to say hi and thank you to all the people who took care of her while she was sick, and though I wasn't there to see her, it struck me how strange it might be to actually talk to Jessie face to face. Because even though we had this incredibly intense shared experience, in all likelihood, Jessie has no memory that I exist at all. Towards the end of Ladybird, the main character is talking to one of her counselors, a nun. And the nun remarks that it's clear from her personal statement how much she loves the city of Sacramento. And Ladybird's a little taken aback, and she pauses and thinks, and then says, "Well, I guess I just pay attention." And the nun replies, "Isn't attention a kind of love?" In medicine, and particularly in the hospital, we don't always get long stories from our patients. We don't always get long conversations. But I've had many, many intimate moments, and I pay a lot of attention. And for me, that's enough. Thank you.
Hi, I'm sitting here with Peter Barish. How
Hi.
are you, Peter?
I'm great. How are you, Evelyn?
Good. Thanks for coming. I'm very excited to hear you speak about the story that you told at our event on the theme of love. But before we do, I'd love to hear a little bit about you and about Peter and how you decided to come into the world of medicine.
Ooh, big question. So I think I came to medicine in general, like a lot of people, through science. I was really interested in biology and immunology specifically in college. I thought I might be a researcher for a while. So I toyed with doing an MD PhD, and I worked in a lab for a while, but kind of missed the human connection when I was at the bench, and so ultimately decided to just to go to medical school and kind of forego a life of bench science. And in med school, really, medicine was actually one of the only things that I really loved. I think I knew pretty early on that I wasn't going to be a surgeon, and I always liked the intensity of the hospital, and I think it's not only intense medicine, but also kind of an intense connection that you can develop with patients in a pretty short amount of time. Being a hospitalist also allows me to wear a number of different kinds of hats. So one of my passions is medical education, and I get to be, as a hospitalist, a teacher. I get to be a part-time researcher, and I get to have a lot of clinical medicine in my life, which is great. Here at UCSF, we get to practice ICU medicine as well as general hospital medicine as a hospitalist. So that was something that was really attractive to me about the group here, particularly.
You open your story with a reference to a film, Ladybird. And I love that. And I'm wondering, before we get into your story, are you a film buff?
I love movies. I don't consider myself an expert in film per se. I've always just watched a lot of movies. And Ladybird was one of my favorite films of the last year. And I really liked the conversation around it. And it's a very lived-in movie. It's very specific. I really like that a lot.
I love the movie too. And I remember when we first started talking about you telling a story at the show, you said to me, I'm thinking about opening it actually talking about Ladybird. Is that weird? And I was like, no, you have to do that. One of the things I love the movie was its focus on Sacramento and Ladybird's love for the city of Sacramento. And it got me thinking about the idea of place as character. And I'm wondering if you've ever thought about the hospital as a character in your life, especially because, you and I both practice hospital medicine, which is actually one of the only specialties that is specifically defined by the setting, by the place in which it is practiced.
Yeah, that's a really good question. I don't know that I have viewed the hospital as a character. It's, the interesting thing about the hospital, I think, is it's comprised of so many different people with so many different roles and views. I don't know that I feel like the hospital has a particular personality, although now that I say that, I do think that certain hospitals that I've worked in, and I think that you've worked in, definitely have personalities. I think the VA as a hospital has a huge personality.
I agree. I mean, I work at San Francisco General Hospital, which is such a institution with, steeped in so much history around the 1980s and 90s and the HIV/AIDS epidemic and the role that it played there. And then also just kind of having this reputation for being a mission-driven place, but also a place plagued by dysfunction, which is incredibly frustrating, but also weirdly has its charm.
Yeah, and it's, the hospital is in some ways really filled with people who are kind of coming in and out, and it's a very transient place in some ways, especially a teaching hospital with trainees who come in and out, but especially a hospital like San Francisco General. There's so much history there. There's been so much activism in medicine that if you only come through for a couple of years, you might not have access to that. In Seattle, at our county hospital, they have all these old records that are still in the hospital from the Department of Health from the 1910s and 20s. And so for a public health project, I went back and I read about what the public health department was doing in Seattle in the 20s around the flu epidemic. And in that case, it was all there.
It kind of makes you feel like you're a part of a larger story than yourself, which is nice in a way. I would like to talk a bit about that night that you describe at the very beginning of the story, where you're minding your own business, you're in the ICU, this woman comes in, and you're worried about her, and then someone on the team comes up to you and they're holding a needle, and they say, you should keep this in your pocket for the duration of the evening.
Yeah.
And the implication is that you may have to then put that needle into somebody's chest, which you have
Yes.
never done before.
Correct.
And I'm thinking about the fact that I've also never done that, and I feel like I could be called upon to do that,
Mhm.
actually. And
Feels like we could be called upon to do a lot of things
a
that
lot
we've
of
never
things.
done.
And I've been thinking about that kind of sink or swim culture of medicine, the sort of see one, do one, teach one culture. Do you feel like you've run into that a lot over the course of your medical training? And do you think that's a good way to teach or a bad way to teach? Or how do you think about that?
Oh, wow. That's a great question. I think the ICU is very much not necessarily a place of see one, do one, teach one, but a place where you really find your legs in the middle of the night. And it's a place, I mean, certainly I think residency historically has been that kind of place where, there will be some point where you're all alone and you're the only person who kind of is in charge and can sometimes, in some cases, save someone. There are a lot of problems with that, I think, with the patient safety movement and just generally everyone being, I think, a little more concerned about having our trainees practice in a safe environment. The pendulum has swung back much more towards supervision on the sort of autonomy supervision spectrum. It's something I think about a lot, actually, because on one hand, we absolutely should have appropriate supervision of trainees all the time, especially in the ICU where patients are really sick. But I don't think there was a month where I learned more about medicine and about how to do medicine than the couple months that I was in the ICU, and specifically this month where for 12, 16 hours at a time, I was the most senior medicine person in the ICU. If you have a trainee practice, just outside of their comfort zone, I think it can be really beneficial.
I've been to a few workshops lately, mostly around difficult conversations, actually,
Mm-hmm.
and then defining our comfort zone, and then there's our stretch zone, and then there's our panic zone.
Yes.
And that this concept that growth really happens when you're in your stretch zone. And so how do we define the stretch zone? How do we create the stretch zone so that patients are safe, but trainees are learning and growing? I think that's a really difficult question. But luckily, you didn't have to use that needle, did you?
I didn't, no. But there was, I was definitely in my stretch zone for several hours. And I think it's one of the things that I love about the ICU is the fact that so much happens in such a short period of time. You can stand at someone's bedside and you watch things change and you make changes and it has real effects. And over a period of hours, you can do several things that you've never done before. And that can be pretty amazing.
I'd like to talk a little bit about Jessie, this patient that you took care of in the ICU, and your story really about getting up close and personal with Jessie's physical body during her ICU stay, and the intimacy of that and the intensity of that. And then she comes back later to visit and you're not there, and you realize that even if you had been there, she likely would not have known who you were. And I was just thinking about the one-sidedness of that intimacy and how, for you, the physician, it may have evoked a sense of wonder or a sense of attention or a sense of care or curiosity. But how if Jessie had known about that intimate moment, she may have felt a little bit embarrassed or, I don't know, like her privacy had been infringed upon. I bring this up because I had surgery a couple of years ago, and I remember coming out of surgery and seeing these EKG leads on me that had been stuck there while I was unconscious, and seeing these wounds in my abdomen that had been put there when I was unconscious. And then the nurse got me up and told me to go to the bathroom, and I went to the bathroom and I sat down to pee, and it really burned. And I realized that was because they had, since I had been unconscious, put a Foley catheter in my bladder and removed it, all while I was unconscious. And it's just this strange moment of amnesia where that people have been all up in your space. And as a medical student on my surgery rotation, I saw the way that the unconscious body is handled, I would say 99% of the time with great respect and care. Putting your arms out to the side so that you're not compressing a nerve during the surgery, the way you're secured to the table and fastened, and they'll lift a leg and move it in this way. And so just thinking about the difference in how that intimacy might be perceived both from the side of you, but then from the side of Jessie.
Yeah, I think it's a really stark difference. I think it's one of the really challenging aspects of taking care of ICU or surgical patients. I don't do surgery, so I don't have sort of access to patients' bodies in the same way that a surgeon does, but we do a lot of things with patients' bodies in the ICU. We put central lines into patients' necks, and in this case, we make incisions between the ribs, and we put tubes into people's chests, and Foley catheters, and lots of really invasive things to save their lives in a lot of ways. And so I have always felt, if it's necessary to do, it's worth it. But it is an extreme invasion of privacy. And especially when someone is unconscious, either because they're too sick or you've sedated them because they're on a ventilator. I think about that a lot. I think most of the time we're pretty good about being respectful of patients' bodies when they're not able to speak up for themselves, whether that's just draping carefully to only expose someone's chest in the particular area that you need, rather than just taking off all of their clothes, and making sure curtains are drawn so that people can't see in. But it's something that I wanted to kind of touch on in my story because it is such, from the physician side of things, an intimate experience in a very particular way. I feel like I am giving life to somebody. I am saving them. I am helping them. I am staving off a terrible disease. And that requires, in a lot of ways, laying hands on patients. And I think that can be really healing. And it's probably the most intimate thing that I do as a physician. And, when you practice outpatient medicine, you get to develop relationships with patients over time, and that's a certain type of intimacy. And for the most part, I don't really have access to those types of relationships. And I was interested in talking about a type of intimacy and a type of love that occurs, in a really short period of time when it's, only one party is really aware of what's going on.
I want to zoom in on this moment where it's time to place the chest tube. I think it's her fifth or sixth chest tube. Yeah. Her fifth. And you're the one doing it.
Yes.
And you're looking for your landmarks, and you notice that she has this tattoo there. And you and the team make the decision to go one rib space down to avoid going through the tattoo. Mm-hmm. Can you talk about that moment? What was going through your mind?
Mostly what was going through my mind was running through a checklist of things so that I would do the procedure correctly and not screw anything up. We had this particular time, we had the luxury of a little bit of planning time. It wasn't an emergency. And so we were able to kind of pick and choose our spots a little bit carefully. And, this was a patient who had, for those people who don't work in an ICU, 5 or 6 chest tubes at one time is a lot. That's more than I had ever seen personally.
I've never seen it. It's a lot.
And it's a lot of scars. It's literally quite invasive. And this is someone who had been, as we were talking about, kind of exposed and poked and prodded, and had tubes inserted into her chest over and over and over again already. And so when I saw her tattoo on her rib cage, I think my first thought was probably to just avoid any unnecessary indignities. And certainly we could have just gone through it, and then she would have had a scar there. And the tattoo may have looked about the same, or it may have been altered. But this was someone who was going to have such a long road to recovery if she made it out. And at that time, I really wasn't sure that she was going to make it out of the hospital. That I thought anything that we could do to maintain some sense of normalcy at the end of the road was probably for the best, if we could do it.
I'm thinking about the times when patients come into the hospital really sick or even unconscious, and we don't know who they are or anything about them. Sometimes they don't even have their actual name attached to their chart. It's a trauma name. Mm-hmm. So at the general, we have like EM turkey, EM llama. For some reason, they use animals.
Right.
And so what you're left with is piecing together a story based on the person's body, both your physical exam, but also imaging, blood tests. Mm-hmm. And I was thinking to myself, like, how much do you really need to piece together some sort of like minimal story about this person? So for example, somebody coming in and they have scars all up and down their arms that look like track marks from injecting drugs. Or someone comes in and there's an x-ray and you see a razor blade in their stomach that they've swallowed. And just the way that the body can tell a story, piercings, tattoos, scars, amputations, all of those sorts of things. Have you thought a lot about this idea of the body telling a story and the challenge of having to piece together a story when all you have is the body, especially in the ICU when, like you say, patients are often unconscious and intubated and you don't even know their name?
Yeah. I've thought about that a lot. I think you can get so much of a story from such a small amount of information. In this case, she came in with what's called a psoas abscess, which is a collection of pus in her pelvis. And she had that because she was injecting heroin into her groin, which right there tells you a whole lot. It tells you not only that she uses heroin, but that she's probably been using for a long time, because if she's injecting into her groin, then she probably can't find veins in her arms or other sort of easily accessible sites. And as you mentioned, what their face looks like and what their hands look like, and whether they look really skinny, like they've lost a lot of weight, and little pieces of information like that, even though that was basically all we had. I think can tell you a lot about what's been going on in a patient's life. It also can be misleading. It leads you to make a lot of assumptions about a patient, which may or may not be true. I think, in this case, it was clear that Jessie had been in the grips of a pretty serious addiction. But I didn't really know anything else about her life and how she got there, and whether she had tried to quit before, and whether this was, how long she had been using and why she started using. And so I think as I've gotten a little bit further into my career, and I'm still pretty young, I have been thinking more and more about trying to get at the patient story from the patient themselves. Sometimes you don't have access to that information, and you're piecing together bits of a history from their exam, from what you have heard from their family, from their lab tests. But that is often not the full story, and often not the most interesting story.
What you're saying reminds me of a patient who I took care of at the General who had a tattoo that had a racist symbol. And he came in and out of the hospital a few different times and was recently back in the hospital. And my colleague decided one day that she would ask him about this tattoo. And his answer was really surprising. He said, when I was in prison, I felt really unsafe. I had never been to prison before. And I knew that I needed to join a group because the only way to stay safe in prison was to join a group. And I was rejected from this group, and I was rejected from that group, and I was rejected from this other group. And the one group that was willing to take me in happened to be this group that everybody had to get this tattoo. So that's why I got the tattoo. But it actually didn't really stem from like a genuine sense of identification with that. Who knows if that's actually true or not, but that's just what he said. But it really does just go to show that even though you may see something visibly on exam or on the imaging or in the labs, that it may not be the whole story. Yeah,
that's really interesting. I think sometimes the flip side is true, that it's always interesting when what you're seeing, whether it's on exam or in the labs, runs completely counter to the story that you're getting from the patient. And I think we often have to reconcile those two things. For, I've taken care of a lot of patients who, swear up and down that they don't use methamphetamine, but there's the methamphetamine in their urine drug screen. And so you're left kind of piecing together what you think is the right story. And I think as physicians, we are always naturally inclined to look for what is kind of the truth, if that exists. But that often involves kind of taking some leaps and making a story with what kind of all the best information that we have.
I wanted to finish with this image of Jessie walking on her own 2 feet back into the ICU to say thank you to the team and you not being there. And I just wanted to ask, if you had been there, would you have said anything? And if so, what would you have said?
I have thought about this a lot. I think I would have mostly wanted to say hi and just shake her hand and see how she was doing. It would have been, I think, a really strange experience, because I don't know that she would have recognized me at all, and I probably wouldn't have said anything to really explain my role in her care necessarily, other than just introduce myself and see how she was feeling. And that, I mean, certainly for me, knowing that she was alive and walking around and breathing on her own was, I think, the best I ever could have hoped for. So that was more than enough for me.
Yeah, and that's one thing that you say at the end of your story is in our jobs in the hospital or in the ICU, we may not always get the story straight from the person's mouth, but for now, this is enough for you.
Yeah.
Well, thank you so much for coming and talking with me about your story.
Thanks for having me. This was a lot of fun.
Thanks for listening. If you like what you're hearing, please visit our website at thenocturnist.com or find us on Patreon and click donate to support our work. We depend on you, our listeners and our storytelling community, to keep this project going. We'd also be so grateful if you'd leave us a rating and review on iTunes so more listeners can find us. And if you're a student or resident, check out our website to learn more about the Nocturnist Storytelling Contest, your chance to be featured on Season 3 of our show. I also want to give a shout out to our friends at An Arm and a Leg. It's a podcast about the cost of healthcare. Check it out at armandalegshow.com. Special thanks to executive producer Ali Block, podcast producer Marina Poole, program coordinator and head of story development Adelaide Papazzolo, sound engineer Alberto Hernandez, assistant producer Kirk Clockey, our podcast intern Chloe Lassard, social media manager B. Logan, our illustrator Lindsay Mound, our composer Yessie Monroe and the voice of Boaz Monroe, and our fundraising lead Cecilia Peterson. This episode's story was coached by Kirk Clockey. And last but not least, thanks to our storyteller, Peter Barish. I'm your host, Emily Silverman. Till next time, we are the Nocturnists.